Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. I am Dr. Mudassir Shahbaz, Associate Professor of Anatomy, Sahara Medical College, Narawal. And today we are going to discuss about the clinicals of the heart. Means the clinical problems that occur because of changes in the heart. I have selected these clinical things in accordance with the as given in the standard anatomy book of the KLM, because first it is necessary to understand because that this the clinicals of the heart are for the first year and second year students of the MBBS. So keep it in mind that very much detail of the clinical problems is not needed here, and we will try to understand the basics, only the basics of the clinical problems and the detail of those clinical problems, their diagnosis, their management, and further things. They will be discussed in detail in further coming years when you will go to the clinical wards. And here today we will discuss the clinicals of the heart, basis of the clinicals of the heart. So first of all, we will look about the cardiac catheterization. Catheterization normally done in the wards, the venous catheterization in which a granula is put into a peripheral vein, most commonly veins in the hand or veins in the upper limb, distally, to give IV fluids. Here is a cardiac catheterization, that a catheter is put in through a vein into the heart to measure certain things or to give certain drugs. So in a cardiac catheterization, a radiopaque catheter is inserted first into the peripheral vein, say a big vein, femoral vein, or subclavian vein, or interjugular vein is used, and it is passed under the fluoroscopic control or sometimes straight into the right atrium and then into the right ventricle, pulmonary trunk, and pulmonary arteries. So you can take the catheter up where you want to put it. You can put it in the right atrium only to measure the right atrial pressure, or you can put it, take this catheter to the right ventricle to measure the right ventricular pressures into the pulmonary trunk and pulmonary arteries. And when you use this condition, you measure the intracardiac pressure of the right side of the heart. And also the blood samples, they can be taken for the investigation purpose. And you can also put a radiopaque contrast medium through that catheter into the heart on the right side, and X-ray films are then taken to diagnose certain diseases of the vessels of the heart or ventricle of the heart. And you can also receive a radiography that can be performed to see the flow of the dye in the real time. And these techniques, they permit the study of the circulation through the functioning heart and helpful in study of the congenital heart defects. So you can diagnose congenital heart defects such as ASD, atrial septal defects, through when you put a dye through a cardiac catheter. So the thing is how this cardiac catheterization is done. Here you see the procedure is performed under full sterile conditions. All the sterile measures are taken. The area is covered with the cloth, and sterile needles they are used. The surgeon is the doctor is fully washed up for the procedure, and here the needle is put, and in this scenario we can see the needle is put through into the neck, and most probably here will be the internal jugular vein into which the catheter has to be put. And this is the technique how they are put. First of all, through a normal syringe of 5 to 10 cc, then first you confirm that where is the location of the internal jugular vein. Then here you can see through this the introducer is put into the internal jugular vein, and then through this the catheter will be put into the vein, and that catheter will move through the internal jugular vein, then into the brachiocephalic vein, and then it will move into the right atrium and right ventricle where you want to put it. So here is as you are seeing the technique of putting up the central venous catheter. This is called a CVP line that is routinely used to put in the ward to measure, to give certain drugs that cannot be given through the peripheral line, or to measure the right atrial pressure in critical ill patients. So you can see here the internal jugular vein is used. How, first of all, not to mention that full sterile condition is used, and here first confirm the vein that you are in the vein, not in the artery. When you are confirmed, then you put the catheter into the vein, and catheter is put first introducer, then after the introducer, then you put the catheter into the vein, which is a measured one, and that will tell you that you are in the right atrium or in the right ventricle. So a central venous catheter is a special IV line that is inserted into a large vein in the body. Large vein, internal jugular vein, subclavian vein. I will show you the other veins which are used. So into a large vein, these several veins are used for the central venous catheter that is located in the shoulder, subclavian, neck, internal jugular, and in the groin region, femoral vein. These are used to put the central venous line. The previous slide I have shown you the central venous catheter has been put into the internal jugular vein. So here you see same catheter has been put into the through the subclavian vein. Here is the catheter which is going inside first in the subclavian vein, and then the technique you can see is below the clavicle at the junction of medial lateral 2/3 and medial 1/3. The direction is towards the neck and towards the sternoclavicular joint, and when you move into this direction, first confirm that you have entered into the uh, uh, vein. And when you recall the anatomy of the vein, that is lying superficial to the muscle that is the scalenus anterior over the first rib, and then it joins behind the sternum with the brachiocephalic vein, with the internal jugular vein, and then it forms the brachiocephalic vein. This is right side, so this will be on the right side. Here you can see the direction of the catheter, and after the catheter has been put, it has been secured at the side. And here you see the different ports, 1, 2, 3 ports. One of these ports can be used for the purpose of measuring the pressure. Other ports are used to give the fluids which cannot be given through the peripheral line. These are the large molecular volume that should be given through the central line, and certain drugs that needed to be given directly into the central line into the heart. These three ports are used. through the central venous line. So this approach is through the subclavian vein. Here you can see direction of the vein. When you will read the book, you will see the direction of the catheter in the angle towards the neck. Here is the approach into the internal jugular vein, that the two bellies of the sternocleidomastoid muscles. Through this you move, first you put a needle, confirm the internal jugular vein, then you put a catheter through the introducer. First you put an introducer, then you put the catheter that will move straight down through the internal jugular vein and then into the brachiocephalic vein, right side brachiocephalic vein, and then into the right atrium. The right side is most commonly used because the pathway for this is a straight one. You can come through the left side if you are unable to use the right side, but this will be a more curved pathway and a long catheter is needed to be put through the left side than on the right side. So the right side is more feasible, more easily approachable than the left side. So most commonly the right side is used. And this is above the clavicle. You can see above the medial end of the clavicle. First you feel the carotid artery pulse, and lateral to the carotid artery pulse you put a needle through. Most of the doctors, they use the needle put is through the clavicular belly of sternocleidomastoid to approach to the internal jugular vein. So in this way the central line is passed into the internal jugular vein. Then here you can see the groin region. First you feel the pulse of the femoral artery, and then you move your hand medial to the pulsation of the femoral artery and put a introducer needle and introducer into the femoral artery, and through this also the catheter is put into the central venous line. But this catheter, this is common sense that it will be a very long catheter is needed to be put through this. So this vein, femoral artery, is very less commonly used. It will approach only into the inferior vena cava mostly, and the drugs and the fluids can be given, but the pressures cannot be measured correctly from the right ventricle or the pulmonary trunk. So, but for the purpose of fluid and the drugs, the femoral vein can be used. Here you can now recall the sequence of the relation of the structures in the groin region where to feel the femoral artery. And here is the inguinal ligament, pubic tubercle, lateral to the pubic, below and lateral to the pubic tubercle, and mid-inguinal point. You see, first you feel the pulse of femoral artery, and then you put the needle medial to it, medial to the pulsation of the femoral artery. So this is how the femoral catheter, central venous catheter through femoral approach is used. So again we see from the beginning, we see first approach is through the that is the internal jugular vein. So the things that we have learned is that full sterile condition is used. First, the vein is confirmed through a normal syringe, and then after confirmation of the vein, then you put an introducer, and here you can see in the neck region, this will be through the clavicular head of the sternocleidomastoid, and direction you can see. It will be lateral to the pulsation of the common carotid artery, so that the artery should be avoided from the puncture. The vein should be punctured because the hazards will be created. And there are precautions not to damage the pleura in the apex of the lung, cervical pleura, and avoid the other complications. And you direct the catheter into the right atrium. The other way is through the subclavian, and here you see the subclavian. It's an angle of 45, and it's towards the right-sided sternoclavicular joint, and it's about the medial side. Here you see out on the outer border of the upper border of the first rib, where the vein passes over it, superficial to the scalenus anterior muscle, and deep is the artery one, so you remain superficial. First you confirm the vein, and then you put the catheter through the introducer, and then this through that introducer the central venous catheter is put into the subclavian vein, and it is secured at the place by a thread, and then the ports you are seeing here which are used. And then here is the neck approach we have seen, and femoral approach. So purpose of the central venous catheter or line CVP line is to measure the central venous pressure. That's why it's called as CVP line. Actually, it is a central venous line, but you can measure the central venous pressure through this catheter. You can apply the venous access when no peripheral vein is available. So when no the veins, all the veins are collapsed or small one, then you can choose this way. Administration of the vasoactive medication which cannot be given peripherally, that is the life-saving drugs such as adrenaline, noradrenaline, other nitrates, they are given directly through the central venous line. And when the patient need the expansion of the blood volume, and then Hemacell and other drugs which are very heavy IV fluids, large molecular IV fluids that cannot be given through the periphery, they are given through this central line. And administration of hypertonic solutions that I told you. And also one point is given here for total parenteral nutrition. The central venous line is used. So at this stage, we need to know the sites through which the central venous line can be put, and we should need to know into which vein is used to put the central venous line, and we should know the basic precautions, central sterilization, confirmation of the avoidance of the complication, and the purpose of the CVP line that should be known as this one. When you will go to the clinical side and will then see the procedure yourself and try the procedure yourself, then you will study in detail about the central venous line. Now we move further. So we come first to the congenital heart defects. Here you see that before birth, here is the right side of the right atrium and on the left side left atrium. We know that before birth there is a foramina ovale which is between the septum primum and septum scandum. Here is the septum primum and this is septum scandum. There is a foramina in the septum scandum, and septum primum acts like a valve. So one way of flow from the right side to the left side is maintained before birth, because the whole oxygenation and nutrition come from the right side before birth in the uterus through the umbilical veins. But after birth, there is no need of this foramina, because the left side is supplying the blood to the whole of the body through the left ventricle. So this foramina needs to be closed, and this septum primum, here you can see, is becoming closer to the part of the septum scandum, and the foramina is closed. And when we were studying the structure of the heart, and we have seen during the internal structure of the right atrium that there left is only a fossa which is named as oval fossa, fossa ovalis, which is a remnant of the foramina ovale. So if this foramina ovale is not closed, or septum primum is deficient and unable to close the foramina, then what happens? It leads to a atrial septal defect in the atrial septum. So this is a congenital anomaly in which the interatrial septum is incomplete closure of the foramina ovale. That leads to atrial septal defect, the defect between the two atria. Is the right atrium and the left atrium. So this will be a defect between the right and left atrium. A probe patency is present in the superior part in 15 to 20% of the adult. So that leads, a probe patency means this will cause no hemodynamic and abnormalities or no significant clinical symptoms. So this is not treated, and the observation is only done to observe this atrial septal defect. So clinically significant ASD vary widely in size and location and may occur part of more complex congenital heart disease. Means that if it is only probe-like, so insignificant, only observation is done. But if it is a larger one and is associated with other congenital heart disease, other defects in the heart, a transposition of great vessels or defects in the ventricular septum or other defects, then you have to consider the atrial septal defect. The large ASD allow the oxygen blood from the lungs to be shunted from the atrium through the ASD into the right side, and this will cause the enlargement of the right atrium and ventricle, and also the pulmonary trunk will dilate. This left to right shunt of the blood overloads the pulmonary vascular system and hypertrophy the atrium and ventricle and pulmonary arteries. Obviously, because if high pressure blood will come from the left side to the right side, so the right atrium will dilate, right ventricular will dilate, and also the pulmonary trunk will also dilate. This will cause. This is large ASD will be done. The anatomical type of the defects in the atrial septum are shown here. The ostium secundum defects are secundum AST. The defect is mainly in the formation of septum secundum. Ostium primum or primum AST. The defect is mainly in the ostium primum. Sinoseptal defects, sinovenous SVC type, IVC type, superior vena cava type, or inferior vena cava type, sinoseptal defects can be seen. Or coronary sinus AST means where the coronary sinus is opening into the right atrium, there will be defects in the atrium septum. So here are the four sites have been shown here. First is in the secundum, 75%, ostium primum 20%. Here is the 1, 2, 3, and 4. Is the one in the defect in the ostium secundum, 75%. Here is the 2, number 2, ostium primum 20%. Sinus venosus ASD 5%. Sinus venous, where the absorption of the superior vena cava, inferior vena cava into the right atrium. Here is the defect. Coronary sinus, here is the coronary sinus, ASD only less than 1%. So secundum ASD are very common, 75%. The atrial septum defect here occurs here. Further detail of the ASDs, that is sign and symptom. If the ASD is larger one and the cyanosis is produced or not, and the when to operate, when not to operate for to close, which type of atrial septal defect needs to be closed earlier, which type of ASD needs to be closed later on. That is that will you will see when you go to the clinical side. Here, what should we know is that the atrial septal defect is the defect in the atrial septum, and this is of four types: in the secundum, primum, in sinus venosus, or coronary sinus. ASD. These are the main site of the ASDs. And then we come to the ventricular septal defects. Is a congenital defect in the interventricular septum that allows shunting of the blood between the left and right ventricle. So, the first one was between the right atrium and the left atrium, but here there is a defect in the ventricular septum, and shunting of the blood is from the left side to the right side, because after birth the pressure on the left side is much bigger than the right side. The left side pressure is 120 millimeter of mercury normal, and the right side pressure is 35 to 40 millimeter of mercury. So blood will shunt from the left side towards the right side. So ventricular septal defects, we know that when we have seen the ventricular septum we were studying, there were two parts of the ventricular septum. One was the membranous and another was the muscular part of the ventricular septum. And they develop separately, the membranous part and the muscular part. So the common site of ventricular septal defects occur in the muscular part. Most commonly, it is the muscular part where the ventricular septum defect occur. Here we see in this diagram that there is a defect in the interventricular septum. So the blood can flow through this ventricle, the defect from the left to the right and right to the left. During diastole, the blood can flow from the right side to the left side, and during the systole, the blood will flow from the left side towards the right side. This VSD rank first on all list of cardiac defects. Isolated VSDs are 25% and of the all congenital heart disease. And the size of the defect varies from 1 to 25 millimeter. So you can well imagine, if the size is only 1 millimeter, how much difference it will make, and if the size is 25 millimeter, how much effect it will produce. But we should know that the VSD is the first on all list of cardiac defects, and isolated is 25% of all congenital heart disease. AVSD will cause a left to right shunt through the defect. The blood will flow during the systole from the left to the right side. A large shunt increases the pulmonary blood flow, which causes severe pulmonary disease. So when the blood flow through the pulmonary system will be larger and more pressure will be generated, there will be a hypertension in the pulmonary side. This will produce a hypertension in the pulmonary side, in the vasculature, which is in the lungs, in the pulmonary system. That will produce its effects other than the hypertension which is produced, otherwise hypertension of the peripheral on the arterial hypertension. But the pulmonary hypertension is a dangerous condition. It has 6 graded, and 3 of which are up to 3 it is reversible, and after the 3 it is not reversible. That grade you will learn later on when you will go to the clinical side. Here to mention and to know is that the pulmonary hypertension, increase in pressure in the pulmonary system, will be seen when a large VSD is present, because of pressure generated by the left side, which will shunt the blood to the right side in high pressure. The much less common VSD in the muscular part of the septum frequently they close simultaneously. If the size of the you can say VSD only 1 millimeter or 2 millimeter, that it can close simultaneously itself. But with larger VSD, they need to be treated and the surgeries need to be done. They need to be repaired, but through the surgery. The types of VSD that can be conal septal VSD, rarest VSD, and the ventricular septum just below the pulmonary valve. Here is the pulmonary valve, just below the pulmonary valve there is a VSD, and that is the conal septal VSD, and it is a rare condition. And perimembranous VSD located near the valve, near the valve, near the valve. And this type of disease is one of the most commonly treated by surgery because this can be closed very easily. Treated by surgery because most do not close on their own. These VSTs, which are perimembranous VSTs below the pulmonary valve. So they need to be repaired, and most commonly their successful surgeries are done. Other is the atrioventricular canal inlet VST. VST here where the this VST is associated with the atrioventricular canal defect located underneath the tricuspid and mitral valve. Underneath these valves, tricuspid and mitral valve, underneath these defects are basically defect in the atrioventricular canal. And muscular VSD, most common type of VSD, it is an opening in the muscular portion, of the lower section of the ventricular septum. A large number of these close spontaneously and do not require surgery. Large number of do not require surgery and close spontaneously. The muscular one. Here this VSD, here this one, which is number 2-1, that is the perimembranous below the pulmonary valve. This is most commonly closed by the surgery because this do not close spontaneously. This one, conal VSD, is uncommon, very uncommon, rare one. Atrioventricular canal defects will be located under the tricuspid and the mitral valve. So these will be in the membranous part. The muscular one, they are the common one, but most of these defects they close spontaneously and they do not require the surgery. So here is the classification of chronic cyanotic heart disease, acyanotic congenital heart disease, acyanotic, cyanotic, and then there is the left-right shunts, overflow, outflow obstruction, then the cyanotic heart disease tetralogy of fillet transposition of great vessels, atrioventricular septal defect, and these conditions, they are very much discussed in the embryological portion of the development of the heart and development of the great vessels. And these outflow obstruction, pulmonary stenosis, and valvular defects that can develop. Then there are the ASD and VSD and patent ductus arteriosus. Most of these congenital defects, they are more discussed in the during the discussion in the embryological development of the heart and great vessels. So in the next lecture, inshallah, we will discuss the percussion of the heart, stroke, and the valvular heart disease, because these are related with the valvular heart disease. So this was about the initial introduction, and inshallah we will see next in the next lecture.